Hi, everyone. Good evening. My name is Alex Birdsey. I'm a first-year medical student here at the University of Chicago. Thank you all for joining us, and welcome to our panel discussion on the business of care, navigating healthcare in a financialized era. Big thank you to the Chicago Forum for hosting this tonight, as well as the Zell Family Foundation for their support. The Chicago Forum's mission is to promote understanding, practice, and the advancement of free and open discourse at the University of Chicago and beyond. In the past year, we've hosted many different events, and we're really excited to finish this year on such a fantastic panel and dinner tonight. So thank you again for coming. If you're interested in attending more Chicago events or getting involved, feel free to join our mailing list or talk to us a little bit more. Follow us on socials and we'll get you connected. So tonight we're going to be talking about the state of healthcare, which, if you didn't know, makes up about 20% of our country's GDP. And about half of Americans have reported saying that they're having trouble paying their healthcare bills, with costs increasing and a new trend in private equity making more and more investments into healthcare. So I think that about past 10 years, there have been about $1 trillion in transaction alone just in the healthcare field by private equity. And everything going on politically as well. We're really excited to hear what the panel has to say about kind of the public sphere going on right now in the present and what the future holds. So with that, I would like to introduce Stefan Baum. He is a fellow medical student with me at Pritzker, and he's going to introduce our panelists.
Thank you, Alex. Good evening, everyone. So as Alex said, I'm also a first-year medical student at the Pritzker School of Medicine, and I have the honor of introducing our distinguished panel of faculty and experts from across the university who bring their diverse insights to our discussion today. So I'll be a little bit out of order, but I'll start with Dr. Elbert Huang, who is a professor of medicine and public health sciences, as well as the director of the Center for Chronic Disease Research and Policy at UChicago. He's a primary care physician who studies health policy at the intersection of diabetes, aging, and health economics. Professor Ream Qato is an adjunct assistant professor of healthcare management at Booth. She's a pharmacist by training and works on pharmaceutical strategy and pricing as a senior director at McKesson, the nation's largest healthcare company that delivers 1/3 of all pharmaceutical products consumed in this country. Dr. Dov Bruch is an assistant professor of public health sciences, whose research focuses on the financialization of healthcare, including research on how PE ownership affects health outcomes and costs. Dr. Colleen M. Grogan is a professor at the Crown Family School of Social Work and the academic director of UChicago's graduate program in health administration and policy. She's also the author of the book Grow and Hide, a look at the history of government and healthcare in the US. And last but certainly not least, Dr. Matt Notowidigdo is a professor of economics at Booth, specializing in labor and health economics. His work examines issues such as how public health insurance affects labor supply and how income changes impact health spending. So with that, I'd also like to introduce our moderator for today's discussion, Ahmad, who's a graduate student at the Booth School of Business and Harris School of Public Policy, and he is the co-president of the Forum's student board. So please join me in welcoming our fantastic panelists.
A quick note on the format: we're going to spend the next 15 minutes in discussion, and then we're going to save about 15 to 20 at the end for audience Q&A. So please save your questions for the end. And additionally, we are recording the event and are going to post it on the Forum's YouTube channel at the end. So without further ado, we framed the entire panel around this idea that healthcare is increasingly financialized. So I want to ask the panelists, starting with Matt, going down, to just spend 1 to 2 minutes answering the question, do you think that's the case? Do you think that healthcare is becoming increasingly financialized? And if so, how do you see that from your discipline and in your corner of healthcare?
Sure. I'm going to interpret the question increasingly financialized as meaning increasingly driven by corporate interests or for-profit decisions. With that definition, I think there's 2 ways I think about it. First is just looking at the share of healthcare spending that's public spending versus private spending, on that dimension, actually, the share of government spending, share of healthcare spending that's public spending has actually been going up over the last couple decades, largely because of the growth of Medicaid and Medicare. So I think that's a little bit of nuance I want to start out with. But if you zoom in on Medicaid and Medicare, which is a lot of where my research focuses on, Medicare and Medicaid are arguably becoming increasingly financialized because of the rising growth of private companies that deliver Medicaid and Medicare through things like Medicare Advantage and Medicaid managed care. Those are delivering publicly financed healthcare through decisions made by private companies. And so in that sense, I think you do see some rising financialization. Joseph?
So I'm going to probably diverge a little from your definition, Matt, and describe financialization as the increasing financial firms, financial actors, financial motives in the economy and society. This will probably be a bit of a divergence depending on your disciplinary orientation, but within economic history and economic sociology and increasingly in public health, we are thinking about financialization in the context of the growth of financial firms within the economy broadly, but as it relates to healthcare, we're thinking about the ways in which healthcare, and I think importantly, health, social determinants of health, population health, have become financialized. So we're thinking about not only how does financial firms like private equity, hedge funds, venture capital firms, real estate investment trusts increasingly penetrate the healthcare system, but also how healthcare institutions, healthcare firms themselves increasingly mirror the logics of finance. And then finally, we're thinking about the ways in which households are increasingly embedded within a financialized era of capitalism. That means the increasing financial tools, financial instruments. That means the increasing reliance on debt at the household level, medical debt. We think about financialization broadly, but we also are interested in thinking about how this new era of capitalism is particularly unique to healthcare and the health system. That isn't to say these definitions need to be antagonistic. In many ways, the amounts of profiteering, and you brought up Medicare and Medicaid, also have been financialized, but we probably might differ slightly on what that actually looks like in practice.
So I am going to probably use a different definition of financialization from the perspective of a practicing doctor. And in my definition, I'm thinking about are financial considerations becoming an increasing part of medical practice? Are doctors and hospitals having to think about money as they take care of people? So I think your question was a binary one. Is it yes or no? And I think there actually have always been financial considerations present for a hospital, for an individual doctor in a solo practice or a dual doctor practice. It's just that it may, I think, the environment or the financial environment, the incentives, the available medications, technologies for treating people, the actual costs of care have actually changed dramatically over decades since the creation of Medicare and Medicaid. If you talk to older doctors who practiced in the 1970s, they describe a golden era where there were basically no one was telling them to restrict spending at all. So they would bill Medicare just at will. Because there were no DRGs, there was no regulation over hospital stays. Medications there were not as many medications available, but clearly over several decades now, financial considerations are a routine part of medical care in 2025. If you're a specialist, you encounter prior authorizations on a regular basis. I'll describe that as the hand-to-hand combat of medical cost containment. That's how we have designed it in the United States. It's a hand-to-hand combat. So every doctor experiences prior authorizations. That is an example of financialization in everyday practice. The amount of time you spend with an individual patient in visits, that's all due to financial considerations, reimbursement or per minute you spend with a patient. So it's always been there. It's just more obvious and more part of the daily life of a doctor now.
Yeah, and I think, so my definition, I think fortunately aligns with some of what we've talked about, where it centers around how do we think about returns and outcomes, and are we maximizing returns for from an industry perspective without foregoing health outcomes for a patient. And yes, I think we're seeing it. We're seeing a lot more, and we're seeing it a lot faster. We're seeing a lot more vertical integration, which has been a thing for the past decade, but we're seeing also horizontal integration where practices are buying practices and there's more efficiencies within healthcare systems. But I think it's oftentimes we think about it and it has this negative tone to it. And it's not always a bad thing. I think healthcare is massive in the US. It's a fragmented industry. And as long as we're using financial capital in a way where you're not disincentivizing or not foregoing positive health outcomes for a patient, then it could be a good thing. One example of that is in the US. The US is known to bringing more innovative treatments to therapy a lot faster. And that's increasingly so. FDA is approving more and more drugs each year. Now, can patients pay for those drugs? We'll get to that in later part of this conversation, but we are bringing drugs to market faster, and they're getting delivered on time to patients where they need it, when they need it. So I think there's a lot of trade-offs when you talk about this, and looking forward to the discussion about those.
Okay. In, I suppose, true University of Chicago fashion, I think I'm going to disagree with many of you, but not Joe. In part because Joe and Victor Roy and myself wrote an article that was published in New England Journal of Medicine about a year ago now called The Financialization of Health. And we really tried to kind of define what financialization in health is. And I do think it's important that to define terms, and so that we all kind of understand what do we mean by this term financialization. And the way that we talked about it in the paper is Joe, already discussed. I guess what I would add to that definition that's really specific to the healthcare system is that the reason we called it financialized, and definitely increasing financialization, is that you see it not just by the entrance of financial actors like private equity, but also venture capital firms, hedge funds. That's a fairly new phenomenon in the US healthcare system. So really starting to emerge quite substantially after 1965 with the emergence of the capital markets. I can talk more about that. But prior to that time, investments in healthcare capital investments came from government. So in the modern era, that really is a major shift. And I think it's important to recognize that. What does it mean for us in the US healthcare system to primarily rely on private capital for capital investments, right? That's a major shift. Second is a major shift is the healthcare entities in the US healthcare system, so hospital systems, pharmaceutical companies, insurance companies, are beginning, and well, I should say have been acting like financial actors for at least the last decade. And that's a pretty major shift. So their investment arms are in many cases bigger than their operations. And that can kind of make or break a hospital, for example. So when it was reported and that hospitals came out in the red, and then there was an article in Health Affairs showing that the reason they were losing money was not due to their operations or low government reimbursement, as hospitals like to claim, but due to bad investments. Right? So they lost money on their investments, and that's what made the hospital go into the red. So that's, again, back to the question, good or bad, but that's different. It's important to recognize the way in which hospital actors in the healthcare system, not the financial actors, but hospitals, pharmaceutical companies, they're acting like financial actors. That's quite different. Finally, and Joe alluded to this, because we have rising medical debt, maybe due to financialization, consumers are more and more at risk. And our policy response to that is to allow financial actors in collaboration with many providers, such as hospitals, to offer medical credit cards to deal with that debt. So all the way down through the system, we have patients facing now a financial solution to the problems emerging in the healthcare system. And I think on all three levels, it's just really important to see how it's become financialized.
Clearly some disagreement on the definition and whether it's...
I should just say that in the paper, we make a distinction. We have privatization, we have corporatization. What I see Matt and Albert, and maybe you as well, Ream, talking about the business of health. We've had the business of health since hospitals started in the 1920s. So that's not new, right? To me, that's not new. Levels of privatization, we've had nonprofit hospitals, 60% of the US healthcare system. That's not new. That's been around since the 1940s, right? Pharmaceutical companies, they were largely like public and at the turn of the century, but they've been private for a long time, right? Privatization started in the 1970s. That part's not new, and I think in our article, we really try to make a distinction between corporatization and privatization and financialization. And I think those distinctions are important.
So maybe then to shift into causes and drivers and to stay with you on this point, Colleen, you obviously wrote a book on the history of healthcare and government in the United States. How would you say American healthcare got to the point that it is now?
Well, on the financialization part, I think what was really important, as I mentioned, that prior to 1965, most of the money for capital investments came from government, also philanthropic investments. But when you look at the data from 1940s and 50s, we have in our minds that philanthropy was doing a lot of the building of hospitals, but it's a pretty small percent. It was really government that was doing the heavy lifting. In the 1960s, there was the emergence of the tax-exempt bond. And at the same time, around in 1965, when we passed Medicare, what was written into the legislation was that Medicare would reimburse for interest and depreciation. And those two things combined increased the reliance on the capital markets, especially from hospitals, but that kind of moved the capital markets into the healthcare system. What was considered prior to that a pretty risky investment became a very safe investment with those two mechanisms. That was very important. So by the time we get to the 1980s, the capital markets have really moved into the healthcare system. And then we have all these other policies, deregulation of the financial markets, encouraging private, financial instruments, such as in, private equity, hedge funds, venture capital, that allow for lack of disclosure, lack of transparency, a much more favorable investment profile for the leverage buyouts. That's all government policy that's encouraging that. In addition, specific to the healthcare sector, we have a lot of increases in government public spending that financial actors are taking advantage of. So the increase in private equity investments in the healthcare system really started to increase quite dramatically after 2010, after the ACA was passed. So you look at things like Medicare Advantage, private equity is all over Medicare Advantage. That's 100% funded by taxpayer dollars, right? Same with nursing homes, same with hospice care. There's numerous examples where it's public dollars that are allowing for private investment. And that's, so by definition, right, the government is encouraging that. So when we think about how did this come about, we can't ignore the fact that we have government policy that's encouraging financialization.
Matt, as an economist, how would you add to the take or potentially disagree?
I think I agree with all of that. So let me stop disagreeing for a time being. I think in one of the ways that U.S. healthcare gets beaten up a lot is that we spend a lot of money and don't seem to get a lot out of it. Like there's been a lot of big growth in healthcare spending overall. Maybe to complement what Colleen was just saying, I just want to establish as a fact that healthcare spending as a share of GDP is going up all over the world, even in healthcare systems that we would say aren't especially financialized. And I think to complement a lot of the factors that have been raised so far, I just want to assert like another important factor that I think is common across the US and other countries is a lot of the technological progress that I think was discussed at the beginning. I think a common cause of rising spending is partly that healthcare has gotten more technologically productive and perhaps at a greater rate than other parts of the economy. So when you look at countries like Sweden, where the healthcare spending as a share of GDP has doubled, it's doubled in Japan, it's doubled in Germany, even without the financialization, I think you need to also start thinking about whether we're spending all of that money because of new technologies that are worth it or not. And to me, I think the difficult trade-off is when you see these new technologies that are so expensive, who gets to decide whether we pay for it or not? Is it the financial actors, is it government, or is it somebody else?
And Ream, I wonder, as someone that's in the industry, have the explanations you've heard just now, do they feel consistent with your experience?
Yeah, I think they do. I think there's multiple examples in industry where you see now I'm hesitating whether it's capitalization or financialization or what corporatization of it, but functionally you have the opioid crisis, right? And with the opioid crisis, what happened was over time, with all the legal settlements that came out of it, there was then a priority of the patient first, right? And there were financial incentives to do that. Supply chain is often something that where you have more increased data, increased accuracy, more technology in place that there's a financial incentive, but there's also a care incentive for the patient, where the patient then is being able to access a medication more quickly. So I think in those examples, it goes hand in hand from a financial perspective and a patient outcomes perspective. So yeah, I think it all aligns with what we're seeing from an industry standpoint.
Got it. And Joseph, Elbert, anything to add on the drivers and how we got to this point before we move on to the kind of impacts today?
Well, let me just say, Colleen, I apologize for misusing terminology. I'm just a country doctor, so I'm mixing up. But all these things are happening at the same time, right? The complexity of the business of healthcare, consolidation, financialization, they're all happening at the same time. The only thing I would say is that from the perspective of, like, let's say you're a practicing doctor, you'll notice that there are fewer and fewer doctors in solo practice anymore because they are increasingly becoming employees. And I think that is part of both probably consolidation and also financialization. You hear stories about doctors selling their practices likely to private equity as well. So yeah, the very practice of medicine is changing because of all these forces.
Yeah, I think the only thing I would add is that it's easy to start at the healthcare level and to only look within healthcare. But I think what's nice about this terminology of financialization is this is a larger trend that's happening across industries. So finance wasn't always, unfortunately, so many of my students are here, they've heard this too many times, but for those of you who do not know this, finance was, as an industry, was not always the largest industry in the US economy. It is now. Manufacturing used to be. As manufacturing went down, finance, what's often called, it incorporates real estate and insurance, has gone up. That change in the economy that started somewhere around the 70s and 80s has had dramatic implications for all industries. Housing has been financialized. Agriculture has been financialized. Obviously, this is a panel specific to financialization of healthcare. But it need not be only understood through healthcare, because the use of this term and this concept is helpful because it lends our understanding to broader economic shifts. So these deregulation of financial firms during the 70s and 80s, the expansion of new financial instruments, tax reductions, the democratization of credit, these changes had large economic implications that ultimately affected healthcare. Now, all the ills, I fully agree with you, of our current health system cannot be attributed to financialization, and all of the positives also can't be attributed to financialization. And admittedly, while there's a lot of discussion on private equity firms taking over physician practices and seeing the reduction of independent providers, financialization is only one part of the story, right? As you mentioned, consolidation and corporatization happened even independent of financialization. Now, they've been certainly accelerated because of financialization, but I think for this talk, we're talking about financialization, but it would be inappropriate to kind of subsume all elements of healthcare within this word, although increasingly as financial firms do become more prominent in our healthcare space, it will be harder to tease out, what is financialization versus these other izations, right? So that's helpful.
Thank you. Shifting to the consequences of financialization on healthcare today, I wanted to start with you, Elbert. As a physician, you've mentioned just earlier in this talk how financialization can affect the decisions that a physician does or doesn't make. I wanted to ask you to just elaborate on what impacts of financialization have you seen in your practice, or have you heard from other doctors in their practice, and how it affects the decisions they're making as far as patients are concerned.
Yeah, I'm hesitant to talk because I think I'm mixing up the business of healthcare with financialization. But certainly in terms of like where people practice, where you get healthcare, is a hospital going to be open or not? I think that is all touched by probably financialization. I think Joe and I, we have a paper together around closures of hospitals and where that happens, and what are the drivers of that. I think that's not entirely actually financialization. That's other things happening as well. But so that just the structure of healthcare and where you get healthcare. I will let others talk more about that. Within the practice of medicine, I think the day-to-day practice of healthcare is affected by the changing business of healthcare and how we are reimbursed. It's pretty. I'll give you a couple examples. One is that in order there are new basically there are new ways of paying for healthcare, what we call them alternative payment models, that are a big part of healthcare, at least accelerated by the Affordable Care Act created by Barack Obama. And one of the examples is something called the Accountable Care Organization. So healthcare systems, these products of consolidation, are increasingly embarking and they're enrolling in these huge contracts. And this is a way to, you basically are responsible for caring for over 5,000 people, and you're incentivized as a healthcare system to lower the cost of care, maintain quality of care, and at the same time, and you basically reap the benefits of any cost savings. If you increase costs for the beneficiaries, you actually are penalized financially. So that is driving the behavior, at least in our hospital right here at University of Chicago Medicine, in a big way as we sign up for more and more. It's a bigger part of our business. So one thing you'll notice if you do get primary care here is that you're now, if you're in Medicare, you'll get an annual wellness visit. And that is for a bunch of reasons, mostly financial, I think. One is that they need that to get the right coding for the person's diagnoses, but the health system is financially incentivized to do those practices. There are some elements of it which I actually like, but it's clearly changed the behavior of our clinical practice. Suddenly we have all these Medicare wellness visits that we're doing. So that's just an example where clearly something about the business of healthcare has changed pretty dramatically in the last 10 years or so. You'll notice also there's a big drive to move patients out of the hospital as quickly as possible. The health system itself is also, I think, joined these partnerships with lots of nursing homes because they realize that the cost of care after someone leaves is actually important. So to gain control over that, the health system has now made partnerships with Shirley Ryan. And so health systems become more and more involved in the healthcare from someone before, in primary care, in the hospital, and outside of the hospital. And I get the sense that the health systems want as much control as possible.
Perhaps to your point, obviously there's a specific phenomenon that the word financialization refers to, but this is also the business of care. So
I suspect this is part of private equity is probably entering into healthcare because there's probably money to be made, right? And so one way to make money is to reduce costs and control costs. That's the principle behind all this, a lot of the behavior I'm describing.
And then on that note, Joseph, obviously you've done research here. I'm curious what you would say the impact of financial ownership is on the quality of care.
Yeah, I mean, so first of all, we've already seen there's disagreements on this term, or at least disciplinary differences. financialization also, even within this definition that I've laid out, it incorporates a lot of different actors. So I certainly don't think that there's a universal effect, quote unquote, of financialization. A lot of my research has been within private equity and looking at what happens after private equity firms take over different types of providers. So how would I summarize this research? So we've done a bunch of different studies in different settings and a systematic review. I think at this point, there's obviously a lot of sensationalistic journalism that comes out. Private equity is going to kill your grandmother. Private equity is going to you're going to go into a private equity dentist's office and you're going to, well, in fact, actually I did have an issue, but generally, I think some of the media on private equity has been a bit hyperbolized. That said, I would say broadly, as I read the research and as I've systematically gone through the research, when it comes to costs incurred to patients, generally the research finds that these types of firms increase costs, whether it's through increased prices, allowed amounts, charges. That is almost universally found. Admittedly, one of my own studies does not find that, but broadly, that is the pattern. When it comes to quality of care, again, this is a term that means many different things. The studies cover many different settings among many different financial actors. But broadly, I would say that the evidence so far is mixed towards negative. There's increasing evidence that there are quality implications that are worse after PE acquisition. But I think at this point, it would be inappropriate to say you go to a PE firm and you're just going to die. Although there is some evidence that in certain settings, your risk will be higher. But I would just say the challenge with this research is it's a little bit, it's preliminary. PE the prominence of PE with healthcare has really only been the last decade or 2 decades. The evidence has really only come out the last couple of years. We don't have the long-term kind of assessment. And even when we do have that assessment, one, it might be too late if it does tend to be a problem. But 2, the types of data we use may not appropriately capture the ways in which these firms affect healthcare delivery. And so I just would caution against too narrowly understanding the current literature on financialization. That said, I mean, I do see major concerns. Yep.
So I'm actually going to build off a point that was made here, right? So one of the ways that we think, or I think about healthcare and the business of healthcare or the financialization of healthcare is the different stakeholders and how they're impacted across a patient journey, right? So when you think about the patient journey, you're thinking about where's the patient getting diagnosed? Who's making the choice about the medicine that they're taking or being treated with? Where is that treatment happening? And how does it get paid for? Right? And when you think along those dimensions, the question around whether it's negative for the patient or has a positive outcome from a clinical perspective changes along that paradigm of the patient journey. And that's where we're seeing a lot more private equity and venture capital investment is specifically, for example, on where care happens. So health systems don't want patients coming back and getting readmitted. And because of that, you see a lot more investment in outpatient clinic practices where a patient can go and let's say it's an oncology patient where typically they stay for their infusion and be admitted overnight. They go, they have a nice cup of coffee or a drink, and they're getting infused with their oncology medication with a TV screen in like this first-class experience because it's a private equity-backed outpatient clinic practice that the patient goes in and out, right? So part of it is balancing the patient experience along the patient journey and then the outcome, of course, is a return for the financial actors that are playing a role there.
Got it. Perhaps moving on then to a couple of ethical considerations. You mentioned, Joseph, that financialization is occurring everywhere, agriculture, et cetera, and perhaps there are negative implications to that we should discuss as well. But there's a unique element to healthcare in that you can live or die, right? So it's not just like any marketplace. And so I wanted to jump to Colleen and ask, from a policy and ethics standpoint, what do you see as the biggest issues with this increasing financialization, and not just the financialization, but kind of the evolution of the business of healthcare?
Yeah. So I think there's a couple. I mean, one is there are some really vulnerable populations that cause, I think, particular concerns about ethics. And the reason I would call them vulnerable is that when we think about trying to create a competitive marketplace, it really hinges on the idea that the consumer or the patient has choice, right? And if you're a person of means, you know, even their choices today are becoming more and more limited as consolidation increases, and we have greater and greater monopoly power, right? So that, I think, is becoming very, very problematic for all patients in the US healthcare system because they don't have the power of choice, which, again, this idea of competition, the business of health relies on competition as the incentive to make actors behave appropriately, right? To not just go after the profit motive. So I think that's the first thing. But when we think about really vulnerable populations that private equity has moved into in a pretty significant way, one area is prison health. And in that space, people are particularly vulnerable. They don't have any choice, and they have very little political power when there are concerns, right? So there's been a number of states that rely on private equity-backed prison health care as contracts in their prisons, and they've significantly reduced the patient to client ratios, and adverse outcomes have occurred. So, you know, when we think about adverse outcomes, we just want to really be concerned where it's impacting populations that have very little power to give voice and to try to change things. So prison health is one, methadone clinics. There are some states where all of the methadone clinics are PE-backed. And in 5 states, it's backed by one major PE company. So they have a complete monopoly on methadone clinics. And that not only gives them power over prices and power over how they provide care in methadone clinics, it gives them political power. So these same firms have gone to Congress and argued against take-home methadone care, which most clinicians in addiction medicine today say that take-home methadone would be enormously helpful to clients. And these companies are lobbying strongly in Congress against something which is clinically indicated to be helpful because it increases their bottom line. That still hasn't, the take-home methadone has not been passed in Congress due, I would argue, to the power of the monopoly power of these companies over methadone clinics. The other areas are nursing homes. Nursing homes have very, very vulnerable patients. Again, lack of ability to move with your feet. And that's one of the areas where private equity, we found that PE-backed nursing homes have higher mortality rates. So where I think we see really egregious concerns about adverse outcomes are where we have the most vulnerable populations. And there is where I think we should really be rethinking. You know, I think healthcare it's as I think many of us already talked about, it's not a private good in the way we think about purchasing a car or toys. I think going back to Kenneth Arrow, economists have argued that it's a public good, but especially when we think about vulnerable populations, it really needs, in my view, needs to be thought of as a public good with really some significant governing structure around care and how it's provided.
Matt, obviously we're at U Chicago, where market forces reign supreme. And so I wanted to ask you, what do you think of the role of market forces, the market mechanism, in the industry of healthcare, given the ethical questions we've just raised?
Yeah, I'm going to answer it in reverse order, which is to start with the ethics and then talk about the market forces, because I think I've come to the view, and I think economists are increasingly coming to the view that when you think about the role of government in healthcare, it has to start first and foremost with the ethical considerations. Like economists, including Ken Arrow, came up with creative arguments for why the government should be involved, such as asymmetric information, adverse selection, moral hazard, as like conceptual arguments for why the government should be involved. And I think that those arguments are clever, but don't get at the real reason why the government is involved, which is the ethics, which is just we as a society just don't find it acceptable to let people just sit in the street and die if they need emergency medical treatment. You know, we mandate hospitals have to provide that treatment. And so I think it's important to just start with that you know, we're going to have some system to give some people some subset of care in certain situations. And then the debate is, where do you draw the line? Does everybody get everything, or are there limits? And these are ethical questions, not economic questions. And so that's why I want to start with that. I mean, I think Congress formalized this with EMTALA that was in the news a couple of years ago after the Dobbs decision. EMTALA requires that hospitals have to provide emergency medical treatment for everybody, whether they're insured, whether they're undocumented. And I mean, that's an expression of a social preference. Now, once you've made that decision, then, well, do you want to have any market forces or not in helping to meet that ethical obligation? I think I see that as room for lots of disagreement. In fact, in my own head, I kind of am schizophrenic in terms of where and how should you have market incentives involved. The analogy I've been coming back to a lot recently is really in education, where we also, I think, all agree that education is a basic public right. Everybody should have the right to an education. But that doesn't mean that there should be no market incentives necessarily. So here I will plant the U Chicago flag in the ground and cite Milton Friedman, who argued, you know, very passionately for everybody has right to an education, but that doesn't mean you can't have competition between schools. You can't have vouchers. You could have vouchers, charter schools. You could have managed competition. You could give parents choice. All of that is requiring the government to get involved and decide whether market forces improve outcomes or not. And I think healthcare, frankly, is just way behind. I don't think we've made as much progress in thinking about what's the right way to involve market forces, but I think I'm enough of a Chicago economist that I would think the answer is probably some.
Some, got it. Ream, Elbert, Joseph, anything to add on the ethical component?
I think the only thing that I'm thinking about as you're speaking is it's oftentimes with education and with healthcare, it's the level of education, the level of care that becomes a debate and the access to it. So in some parts of the US, there's amazing care, but it's an hour away, or it's 5 hours away, or it's only in the academic medical center that's inaccessible to you, or you have to get on a bus. So I think that part of the debate becomes, what is the level of care that is a requirement as a public, to make it a public good? And is it the same level across the board, or is it something that changes based on specific requirements?
I'll just pick up something that Matt talked about a while ago about the tension between innovation, cost of care, caring for an individual patient. And so this ethical dilemma comes up routinely for the doctor who, in a lot of ways, actually thinks kind of in just a binary way. If something is going to be beneficial, I want to be able to provide that to the patient. And but on a cost effectiveness plane, there's actually four. You know, a new technology will end up in one of four quadrants. And we as a society have not made any, in the United States at least, have not made any centralized decision making around what is covered, what is not covered, and we've allocated the decision to doctors in this hand-to-hand combat that I described to you. It's decided at each individual. And that creates all kinds of complex dilemmas for when we're making a decision for a patient. So we'll have to at some point wrestle with that. We've decided not to, the Inflation Reduction Act actually introduced for the first time some involvement of government in centralized decision-making around the coverage of drugs, for at least for Medicare. So that may be something, and it looks like the Trump administration has not disbanded that. So we will see how that plays out.
I think I would just add, I think in my class, we read a broad range of texts, starting with Milton Friedman. We actually include your textbook as an excellent representation of the insurance industry. And while I would agree, increasing number of mainstream economists would support, at the very least, government regulations in the healthcare industry, I think they would diverge a lot from the initial intellectual foundations of Milton Friedman. And I think he would reject a lot of what mainstream economists are increasingly are thinking about when it comes to health insurance. And so I would just say in terms of our own ethics, I think as an institution, we need to do a little reckoning of how our intellectual infrastructure has really informed policy debates, has informed policy understandings, how lay people even understand, what is the role of government in healthcare, because we as an institution have actually had a major impact on these conversations. And I guess in today's world, I think what is amazing about this panel is we are able to think through this collectively, and I think it's a real strength of what this institution has to offer, but also something I think we need to think historically about.
Let's turn to the future. So starting with Colleen and moving down, I'm interested to just hear from each of the panelists. We may not agree on how we got here or even what financialization means. Obviously, there's a lot of consequences of that financialization and the evolutions of the business of healthcare. What one or two things do you think need to happen to kind of improve the direction we're going?
Yeah, so I'm going to, on the private equity front, there's a scholar at Harvard University, Zuri Song, and he has a really good sort of like 5 points for reform of private equity. And I think that I would just like endorse those 5 points. One is, definitely around more disclosure, more transparency, antitrust enforcement. There's a whole number of just like really good kind of interventions we can do. Not easy to get past at all, but important things that I think we could do that would address the a bit more oversight in terms of what private equity is doing and more information about what's under the hood in terms of the deals and all these subsidiary arrangements. That said, I do worry that the problems in our healthcare system and the problems of the business of health, that when you think about financialization, as I started out, PE is just one little part to that. And so I do think that little fixes are not going to solve the mess that we're in. I think we need a new paradigm. And I think a big part of that paradigm has to be really kind of rethinking what's the role of government in investing in rebuilding our healthcare infrastructure. So you might call it sort of the new industrial healthcare bill, right? So we have rural hospitals that have been closing at a time, even during COVID, we had rural hospitals that were closing, no protections for them whatsoever. So just really thinking about rethinking public provisioning. Part of the reason that private equity and the capital markets have moved into healthcare is that government receded. That was a decision on the part of the American government and obviously the American public behind it. What's really important to recognize, and I know you want me to finish here, but what's really important to recognize about government receding from capital investments and allowing the capital markets to come in substitution of that is that government money did not recede, right? So there are huge amounts of public financing in the US healthcare system. The US government, at all levels of government, finances at a minimum 60% of US healthcare expenditures. A lot of estimates, pretty conservative economist Mark Pauly has estimated it's about 80% of healthcare dollars are have government subsidies involved, right? So what's happening is we have no control, no regulations, but a ton of public money. So when we think about this new infrastructure development of governance, it's using the same amount of money that's already in the system and perhaps even less. So it doesn't mean more government subsidies for what I'm calling for. It means a reasonable governing structure to rethink how people have access, the allocation of goods and services.
Yeah, I think building off of that, one of the things I think about is what does it mean when there's government involvement, there's government subsidies? What are they where's the check? Where are the checks and balances, and what does it look like, and when do you involve the government to make sure that profit motives are not disincentivizing good care for a patient? What does it mean to have good care? And then the second piece is making sure there's multidisciplinary teams that are involved in these strategic decisions. We have a multidisciplinary panel here where you have a physician, you have an economist, and I think making sure that along that value chain, along the decision tree, if you will, you have an economist, you have a physician, you have nurses, you have clinicians, you have pharmacists involved, people that are seeing the patient, and then you have patient advocates involved as well to make sure that they're all part of the change in the future.
I've lost track of your question, but I will.
One or two changes.
What excites you about the future?
Well,
I went rogue.
I struggled with that question when I read it. But I'll highlight one bright spot in the healthcare system that actually I think has not been touched by financialization, which is actually a system that has grown over. It's the hide and grow story of the federally qualified health center system, which is actually a bright spot within the United States. You may or may not know about this, but it's backed entirely with federal and I think some state dollars. It's a health system. It's the primary care safety net for the United States. It started as 2 clinics in the late 1960s, one in Massachusetts and one in Mississippi, and has now ballooned to 1,300 other sites. Each health center has a community board. So community members make up at least half of the board. There has to be community interest in the formation of the center, and it has to be in a health professional shortage area. It has historically enjoyed bipartisan support. This program has grown regularly with Republican presidents, Democratic presidents. This might be the first time a president has changed or shrunk the program, but is a very unique program in that it is kind of grown. I think it covers at least 13 million people in the United States. And when you compare people getting primary care in health centers that are on Medicaid to those who go to a non-FQHC, they're about 10% less expensive. So there's something about that form of care that has a community connection that saves money and also has it has room to improve in terms of quality of care, but is a bright spot in our health system that people don't talk about.
I think what I'm seeing within my own health policy circles and with the more academic health policy community is a finally kind of an interest of moving beyond just traditional healthcare services and as with that traditional, what we think of as healthcare policy, to think about antitrust regulation, to think about industrial policy, to think about the role of public financing, to think about the role of, what would a governance structure look like? This is so beyond just cost containment, access to care. This is really thinking about the infrastructure of our health system and thinking about not just how healthcare actors are working, but how our larger economy is working to support healthcare and how our government is. So if the question was, what am I excited about? I'm excited that there's an impetus here. I don't think we'd be having a panel on financialization a couple of years ago. And so I'm excited that people within healthcare are also excited about maybe thinking more broadly and more boldly.
I'll try to be specific. So I just want to agree with what Joseph was saying earlier about the impact of private equity in parts of the healthcare system like nursing homes. I think the evidence looks quite concerning. But on the positive side, I've seen some evidence on private equity's involvement in fertility clinics that looks significantly more positive. And that's something that's pretty near and dear to a lot of my friends that have struggled with infertility. The evidence I've seen suggests that when private equity gets involved, it's unambiguously improving outcomes. And so the way that I try to pitch this optimistically is I would love for the government and capital markets to somehow figure out where can private equity make a positive difference and where should we just put a 10-foot pole and keep it away, which parts are more like nursing homes and which parts are more like fertility clinics. And if I can give a second answer to the question is, and maybe speaks to some of the tensions we've been talking about today, is like every year for the last couple of years, I've gone to Seven Wire's annual meeting. So Seven Wire is a local venture capital firm that invests in healthcare companies. And I would say it's the part of the year when I'm most excited and inspired about healthcare, just seeing the kinds of companies that they're investing in and developing in. And so maybe that just speaks to the possible potential of private equity and venture capital if I think about things like fertility clinics and the digital health companies that are being created by Seven Wire.
Thank you. And with that, let's give it up for the panelists. So we're going to shift to Q&A. We've got Alex and Stefan as mic runners. Just feel free to ask your questions.
Hi, everyone. Thanks for doing this. Just curious what your thoughts are on like the difference between private equity choosing healthcare specifically and just the fact that private equity's involvement in the American economy has gotten just incredibly large. That's primarily due to all kinds of regulations post GFC. But like, I don't know, like BP sold all their Alaska assets because the public markets don't like those. And it wasn't another oil company that bought them, it was private equity. And so I think that speaks to a significant private capital market that exists out there that maybe has decided to kind of go after 20% of the economy coincidentally, if that makes sense, instead of just like surgically. And just curious your thoughts there.
I missed the question.
I mean,
So the question is basically, do you think that PE, and correct me if I'm wrong, but do you think that PE is targeted healthcare specifically versus PE is just getting bigger in general and getting its fingers in a lot of places, and its participation in healthcare is no more than its participation in any other industry?
I have a response to this, so I'd be curious what other people. So when I was looking at the rise of PE in healthcare, I was reading a lot of the major, big private equity firms' annual reports over time. And starting really in 2010, but most like every year, they in their annual reports, they would show how healthcare was one of the biggest areas of investment. And it was quite interesting because in the report, they would talk about, to their investors, healthcare seems, like it wouldn't be a good area, a good sector to invest in because it's very expensive. There's huge government involvement. It's heavily regulated. But let me tell you the analysis of why healthcare in particular is a really good area for private equity investment. And what they pointed to was the rise of coverage, right? So that government reimbursement was actually quite predictable. And so it made it a much safer investment. And then, as you said, the growth of healthcare in the economy, that it's a growing industry due to aging demographics, that it's not going to contract. And then I think the third was really more around the lack of regulation around prices. So there's regulation, but they were very clear about where there was very little regulation and how that could be exploited.
I just add a story. I do some work in sort of population forecasting of chronic diseases like diabetes, and one of the most disturbing meetings I've been at is at the American Diabetes Association, where I was like giving results of this forecast of how many people are going to have this chronic disease in the next, where someone would have to require medication for the rest of their life. And the back of the room was full of finance people, basically, because they love the idea of having basically a subscription plan for millions of people that they can tap into that's paid for by, so there are just lots of reasons that healthcare would be very attractive.
Maybe just to build on to that, as a Booth student that has recruited for and talked to PE firms, anecdotally I can say that the dental clinic roll-up, autism care, fertility clinics, like it is a big topic of conversation. And your experience, Elbert, is something that they talk about of how do you identify who you're going to buy as you go to the conferences and you stand in the back. And you know that if you're in a conference where there's 30 other PE guys, like it's a good area. Yeah, it's a good area.
Hi, my question is, do you think that this trend is increasing risk? And if so, do you see ways to reduce risk?
I mean, I think one of the challenges with private equity is the short time frame by which they own the actual healthcare entity. So, and this is a distinction between even other for-profit companies, right? You could be a private or even publicly traded healthcare firm acquiring a health system, but you plan to own it for a long time. A lot of these PE acquisitions result in 3, 4 to 7 year timelines. So in terms thinking about risk in this specific way, I think one of the challenges about, or the concerns about PE acquisitions is the uncertainty and the constant roll-up, sell-off that we've seen in some of the PE acquisitions. There's also the concern that once these PE firms acquire healthcare facilities, they'll sell off the real estate, oftentimes to a real estate investment trust or another type of real estate investment entity. And so there's also a bit of a risk there. Some of my current research suggests that after a real estate investment trust acquires a hospital, you see increased risk of closure down the line. Where's the research on this? I think we don't have enough data to look long term at like the financial performance of healthcare entities that are acquired by PE, but I think preliminary evidence-wise, I think there's some reason for concern when it comes to risk, financial risk.
Yeah, I interpreted the question as like financial risk for the companies rather than like risk for consumers, where I'm not really aware of any evidence on that. I could see it going either way. Like the consumers could end up with more medical debt, like Joseph was talking about earlier, and that would be increasing financial risk for consumers, but I'm not aware of any like rigorous research on that yet. I mean, if you want to draw lessons from other industries, there are some Booth faculty that studied the entry of private equity into manufacturing. And there it looks like there was a pretty clear reduction in financial risk because many of the manufacturing firms, this is the claim made by the researchers, like would have just completely gone under if not for private equity's involvement. So that's actually like reducing financial risk by helping the company stay in business. So yeah, I think it's a good question.
I have a question just about the rising costs of care in general. So there's a lot of developments that are life-changing for tons of people, things like advancements in oncology and genomics and all of this, and it's really exciting. But at the same time, like Colleen, for example, mentioned vulnerable people, and we talked a little bit about that disparate outcomes that people are seeing. And I'm just curious if you could comment on, given that we have a societal preference for as Americans at least, given that there's other kinds of health systems, for really good care on average, or at least expensive care, how we can provide some kind of acceptable amount of care to patients who don't have as much, but then also kind of enable the development without things being too unaffordable for like those vulnerable people.
I will. So I think, a couple of us have mentioned this, that there's this tension between innovation and controlling costs of care. And unfortunately, most innovations increase costs while also improving quality of life. There's actually very few that actually reduce costs overall. So the prime example right now in the news is the anti-obesity drugs. So if you talk to the drug companies, or they'd say, oh, it's saving money, because you prevent all these events that happen when someone loses weight. But it turns out you have to treat a whole bunch of people. There's a number needed to treat in order to save $1. And it turns out that it's not cost saving. It actually increased costs overall. So that is one example of a kind of a tension around just one therapy. But now pile on top of that all the new innovations that we've developed over time. That ultimately what happens is that increased insurance premiums overall. So that's why overall costs of care are going up, because Matt referred to like some sort of floor that economists have talked about as a basis for what is the base, and we as a country have not made that decision about what is the very basic of healthcare that we will guarantee for all people. And so what happens is you go from insurance plan to insurance plan, and the coverage varies, and the Inflation Reduction Act right now only applies to Medicare, so you have to survive to 65 to get national health insurance. Before that, it's a complete, it's chaotic. So we have, I don't know, I don't have a lot of faith in the current current administration is going to make any big decisions in this area or pass any legislation in this area, but it's been needed for a long time. There's actually quite a bit of experimentation at the state level for different state Medicaid programs who are trying to figure out how to cover costs of very expensive medications. And we can look to also Europe for, in Europe, there are countries with central decision-making around what is covered and what is not, which we could learn from. It hasn't controlled costs of care, actually, completely, but it has at least moved some of the decision-making from the hand-to-hand combat I described to you to a central decision-maker.
Yeah, can I just to add on that, I mean, they haven't, all countries, as both of you have said, are dealing with increasing costs in healthcare. That's absolutely true. But I think we do have to acknowledge that U.S. expenditures.
We're number one.
We're not just number one, but we're a huge outlier. So, and a lot of that is coming to around prices, right? We don't regulate prices. And so when you talk about the Inflation Reduction Act, that's the one, finally, after 2003, it was written into the legislation that we couldn't negotiate over drug prices. That was the Inflation Reduction Act that said, okay, starting with 10 drugs, we can negotiate over drug pricing. Now, the pharmaceutical companies said, okay, and this has been their argument for a very long time, and most private actors will argue that if you regulate prices, or really any regulation, the cost to the American public is innovation. Then we won't get the innovative drugs that the American public wants. The problem with that argument, I think, and many economists and health services researchers have been looking into this question quite substantially. So I encourage you to just read the literature here, because especially on the pharmaceutical front, what's really being lost is the amount that government invests in basic research, right? That's that NIH money. And that basic research is super important, because what pharmaceutical companies are doing are looking at the really promising innovations coming out of basic research. And they're not just saying, oh, we'll randomly choose something to do clinical trials on. They're taking the drugs that have the most promise for clinical trials to invest their R&D in the clinical trials. Now, R&D investment it's important. I'm not diminishing that investment, but it's a much lower risk investment than what government made, right? So government is taking on most of the risk in terms of deciding, allowing basic research to figure out what's going to stick and what's not. And the drug companies are actually not taking on as much risk as you would think with R&D, right? The top 10 drugs that came out of pharmaceutical profits were directly indicated from basic research. So I just think that's really important, and what gets lost in this argument is the amount to which the public has already paid for that innovation. Right? So for us to invest all that money initially in innovation and then not get any social return on that investment, I find hugely problematic. And very, very problematic that we then buy into the argument from private actors that our innovation will suffer. We just need stronger negotiation up front over what we expect in return from government subsidies, I think.
So I'm going to build on that a little bit from a pharmaceutical perspective, actually, in agreeing with you. So one of the other things that came out of the Inflation Reduction Act was what's often referred to in industry as the pill penalty, right? And with the pill penalty, the time period that a drug's price gets negotiated by Medicare differs based on the type of molecule it is. So if it's a small molecule, it's 9 years. Biologic, large molecules, 13 years. So a lot of pharmaceutical companies are saying, well, that makes me lose 4 years of my high price, the revenue that I get from a high price. So why would I want to launch a drug as a small molecule when I could do it as a biologic and get get that revenue for a 4-year time period. So I think, unfortunately, one of the outcomes then becomes a manufacturer, a pharmaceutical company decides, even though there is maybe basic research done and this is a promising drug, I need more than just 9 years at a high price to be able to recoup any R&D, presumable like R&D costs. And because of that, I'm not going to continue with trials on this drugs. And a lot of pharmaceutical companies have come out with statements saying that they've decreased the number of drugs in their pipeline that are small molecule products because of the pill penalty coming out of the IRA. Another, tangential point is biosimilars in this country, right? So biosimilars, presumably before, I think it was 2015, the first biosimilar launched in the US, and the purpose of biosimilars is to take these high-cost medications and bring a low-cost alternative into the US economy. Oftentimes in other countries as low as 90% lower than the reference or innovator drug that's coming out. So essentially like a generic, I hate saying that because it's not true, but like a generic version of a branded product. And in the US, there's other stakeholders that play a role in the decision of whether a biosimilar is used for the patient. And those are the payers and the PBMs that really control the formulary that a provider has to follow, going back to your prior authorizations, right? And because of that, then you get more, you have a lack of adoption of this category that has saved other parts, has saved globally billions and billions of dollars into the overall global healthcare expenditure. But in the US, we don't see that benefit because you have PBMs and payers really preventing, there's newer dynamics that's happening there, but generally speaking, they're preventing the adoption of biosimilars because of their own formularies.
Right, and some states are investing, like California,
Yes.
in public provisioning of pharmaceuticals, especially around generics, right?
They've,
For
they've
exactly
invested
this
in
reason.
manufacturing of insulin.
Of
for example.
insulin,
Yep.
yeah.
because-
And Massachusetts does
And
something similar. It's
Michigan
states
has
have
something.
Yep, Michigan, yeah, for exactly this reason.
Yep.
Going back to the question about risk, you talked a little bit about how the private equity companies, they've seen potentially reductions in quality of care. And we know that becoming a doctor obviously takes a lot of money. It takes a lot of time and effort. And it's a big commitment. A lot of people don't start making a big income until they're in their 30s. They come out with hundreds of thousands of dollars of debt. And in previous generations, they were rewarded by being able to be owners of their own practice, set their own terms, make a lot of money. And now they're primarily like 9-to-5 employees of a lot of these privatized private equity firms, large hospital systems, et cetera. So my question to you is, do you think we're creating a sort of incentive system that is like de-incentivizing our best and brightest to become doctors, and we may see like quality reductions because our best people won't want to go into this field anymore because of the like system in place?
As a doctor, I will answer that question. So the answer right now is no. So despite all the things we've talked about, the increasing business of healthcare, consolidation, financialization, I don't know if you've noticed, but it's super hard to get into. Actually, our med school students here can attest to this. The admission rates for, I think, the top 50 or 100 medical schools is in the single digits. And it's extremely hard, competitive to get into medical school. I don't know if that's because it's become, other areas of the economy are harder to enter, but or have become less attractive, and being a doctor remains attractive for a variety of different reasons, but it remains super popular, very hard to get into, and the best and brightest still get into medical school. Now, you may know the history also of the professionalization of medicine, that it's actually a very tightly controlled guild. There are a limited number of medical schools. One cannot just create a new medical school. So it's the number of medical graduates we have coming out per year is highly regulated. The number of residencies is also highly regulated. That part of medical education appears to be quite healthy for some reason.
I wonder, there are these statistics out that the suicide rate among practicing physicians is higher than vets. And so I wonder, and just having taught in medical school students over the years, when they come in, they know very little about the business of health.
Yes.
And they don't really learn about the business of health until maybe a little bit in residency, definitely when they get out of residency. And so maybe part of the problem is they're still going into medical school because they don't really know what is in store for them. I wonder what you think about that.
That's a good point, Colleen. They may actually, the funnel to get may still be the same, but the experience of medicine there may be dissatisfaction in the job later on. Each generation has also changed in terms of what they're looking for medicine, in terms of the medical, their profession. There's increasing interest in more shift work, not being on call for long, for extended periods. And that may actually be better in a more corporatized form of medicine. I had a community member say in a recent town hall that they were quite disturbed by their experience with the primary care doctor recently. They described it as going to McDonald's. So there is something about the experience of going to see a doctor has become more generic or flavorless and depersonalized. And I don't know if I don't think that's the medical school, but that may be part of the business of medicine.
But I do think, sorry, were you going to go? I do think clinicians, not just physicians, but clinicians broadly, they are having a reckoning right now. I don't think clinicians, I mean, we can talk to our colleague Josh Gottlieb, who has a lot of research on physician pay. They tend to be the highest earners of all earners, they tend to be the most likely to be in the 1% of all different types of professions. I don't think that physicians are going to stop making several $100,000s on average. What I do think is there will be a level of moral injury that I think many clinicians, but particularly physicians, are already experiencing and will experience in much more severe ways. I think as whether it's private equity or other corporatized entities, begin to control more amounts of their work and they have less flexibility, autonomy, and authority within this profession, I think there will be a level of injury that will change what it means to be a clinician. But ultimately, I mean, if it's true clinicians go into medicine to help people, I don't think that slight changes in their income structure is going to, but I do think these other aspects of what it means to be a clinician will affect their labor conditions. And that's important because it also means how they respond as themselves, as workers. What does that mean? Do they unionize? Do they fight back? Do they change maybe how their professional societies have historically responded to things like universal health care? I mean, these are changes that they're going to have to also make in response to this new economic shift in our health system.
And on that note, that is unfortunately all the time we have for questions. So let's give it up one more time for the panelists.